moving our entire healthcare system toward. And so we know that our largest healthcare institutions are moving toward that model of integrated care that is accountable for quality, outcomes, and cost effectiveness. So today we're going to learn how HMSA, Kaiser Permanente, the Queen's Health System, and Hawaii Pacific Health are implementing their vision for a transformed health system inspired by the triple aim of better care, better health, and lower costs. So what we're going to do today is have presentations from each of these extremely informed people, and then we're going to I'm going to ask them a few questions to warm them up, and then I'm going to turn them over to you. So all of this in the course of an hour. So we're going to be moving pretty quickly. The 4 presentations, I know that you have the bios in your packet, so I am going to be really skimpy with the intros because I think we want to hear more from them than about them. And so we have Dr. Melinda Ashton, Chief Quality Officer for Hawaii Pacific Health. We have Joan Danieley, Vice President for Strategic Business Development at Kaiser Permanente. Dr. Whitney Limm, Vice President of Clinical Integration of the Queen's Health System, and Hilton Raethel, Chief Health Officer for HMSA. And so the order that we're going to go in today is Joan Danieley, Hilton Raethel, Melinda Ashton, and Whitney Limm. So let's start with you, Joan.
Okay, let's talk about the advantages of the integrated model. Although I have to say that you said we were extremely informed, and I think I may be on the wrong panel. I don't know, we might need to check that out. But how do you define a high-performing system? And this has been looked at by the Commonwealth Fund as well as many others. You know, some of the things I wanted to highlight for the group today is that you need clinically relevant information, and it has to be available to your providers at the point of care. You need patient care that is coordinated across multiple providers, and where the transactions are actively managed, and I will show you another slide on that in a moment. Providers within and across settings must be mutually accountable, and they must collaborate with each other. Patients themselves must have easy access to the appropriate care and to good information. There has to be clear accountability for the total care of your patients, and you need a system that is continually and vigilantly focused on innovation. As we look at leveraging the integrated model, I want to talk first about what does integration mean? And it means different things in different systems and different organizations. But integration is about a shared responsibility for success. And the integration can be along many multiple dimensions between the financing arm of healthcare and the medical care provision arm of healthcare, along the health lines and the illness, because you need both care for healthy as well as illness and sick care. Across the providers, that's what we frequently think of when we talk about ACOs and integrated care, is across providers. And you need care that is a continuum over time. And at Kaiser, we often think of Kaiser babies become Kaiser members as adults. But when you are leveraging the model of integrated care, you've got to have tools in place. And at Kaiser, we have KP Health Connect, which is the Epic system that many people in Hawaii have. Care coordination, performance improvement, and performance innovation must be key. And that patient engagement, such as the web portal and web applications and mobile device applications that we have at Kaiser. One of the samples I wanted to share with you today is how you use tools and information and collaboration in order to truly take advantage of the integrated model. What we have up here, and this is a mock-up, this is not any actual patient's data, so for anyone who's worried about that. But what we have developed from Dr. Brian Lee, who is one of the nephrologists at Kaiser, is he and his staff go through all of the medical record data that we have within Kaiser and look at lab results and test results, which makes it a little bit different than having claims data, because you're not going to actually have the results within your claims data. But they look at the medical record data, and then they identify patients who may be at risk of end-stage renal disease, or may eventually, so many years out, need dialysis. And I don't know if you can see up there, but if you look at the top, they've estimated, based on all the algorithms, that a patient has a 2-year risk of ESRD of 37%, a 4-year risk 52%. And then what do they do with this that you can do in an integrated model that may not be as easy to do when you're not integrated? Well, you can take the population that you've identified and then reach out to the physicians who are caring for those patients. And I call it the reverse referral. Instead of nephrology waiting to receive a referral from a primary care physician, nephrology is mining the data and reaching out to the primary care physician and sending a letter, which is the sample letter is in that little typed area at the right-hand corner, saying, hey, doctor, patient so-and-so is at risk of developing ESRD based on all of this criteria. Let's send them over to nephrology. But you can do that in an integrated system where physicians are collaborating with each other and working toward the same goal. The collaboration and integration also occurs across the entire care continuum. Within an integrated system, you can focus on primary prevention. You can focus on acute management, because people will get sick. And you can focus on post-event management. But you have to be able to coordinate and collaborate across that entire continuum in order to realize all that you can get out of an integrated system. And earlier I mentioned transitions. There are many transitions, and in fact at Kaiser, we have about 1 million patient transitions a year. It's incredible. People transition from hospitals, various emergency rooms, home health, rehab. Within an integrated system, you really need to focus on smooth, managed transitions of your patients. That's how you keep coordinating their care and utilizing the ACO model to its full advantage. Within an integrated system, you must constantly be driving toward improvement. We're all driving toward improvement. Always reviewing your clinical guidelines, developing care management programs, setting very specific, granular, and actionable metrics. We talked a lot about that within the project that Beth has been leading us through. Metrics and measuring and identifying improvement. You also have to have physician leadership and clinician expert champions. These physicians must constantly be cascading communication and operating within a culture that is based on accountability, commitment, and absolutely pride. Pride in what they're accomplishing, pride in the care that they're giving, and a relentless focus on the goals of the integrated system. And I know we've talked a lot about technology, but technology is not an end in and of itself. We have to constantly be improving our technology and improving the quality of our data in order to continue to move forward. And an integrated system must always be focused on innovation. I want to share with you today something that Kaiser opened in 2006. It's called the Garfield Innovation Center. It's a 37,000 square foot center where employees can explore new and innovative ways of delivering care. You'll notice on the slide there's a prototyping space, and you can set up space to make it work like a hospital. You can set up space for a medical office, and you can set up space to be utilized to practice things that would be in a patient's home. What is so wonderful about having this innovation center is that you can actually experience new ideas. You know, you have a new idea, you graph it out, it seems like a great idea. Here you can experience the idea. You can do what we call rapid cycle testing. I don't know if any of you IT people are used to agile methodology, but it's where you change something, test it, see how it worked. If that didn't work, you change it again, test it, see how it works. Rapid cycle testing. And what's really neat about the Innovation Center is when you have a technology that's going to go into a facility that already has an infrastructure, you can try it out and test it here in the Innovation Center, and then you can map out all of the dependencies that that new IT system or that new technology has as it sits within an infrastructure that already exists. I've had the opportunity to spend time in the Garfield Center, both in a simulated operating room, which that was really fun, as they tested new ways of providing care in that setting, and as they worked on how to set up nursing stations so that it gives the best advantage for the patient as you are building and constructing hospitals. And then a simpler one, but one that proved to be incredibly important, was they used the Garfield Center to test ways to give flu shots. And you think, oh, we're giving flu shots, no big deal. But you know, they used the center and tested all different ways you could set it up to make it more efficient, the ways to use the mobile technology in an outside setting. You could practice that there with the mobile technology when you're giving the flu shots. How can we get that information into the patient's medical record in real time when we're in a mobile setting like this? And they tested things like, should we combine adult flu shots and pediatric flu shots? And if we did, what's the most efficient way to do that? And what's the most efficient way to move the patients through the process of getting their flu shots? It's really an excellent place to go to keep your eye on continued innovation within the integrated model. And then last, you've got to keep your patients engaged. And frequently we use technology to do that. You can use it in the electronic medical record where they have visibility to their labs and results. You can let them email their docs. Convenient transactions keeps the patients engaged. With convenient transactions, they can get their prescriptions filled online or manage their appointments online. And then, of course, keeping patients engaged with educational opportunities. So what we have found is that to really leverage and take advantage of the integrated model, you put all of this into a formula and give it vigilant focus on innovation, and you can leverage the model for our community.
Thank you, Joan. Thank you very much, Joan. And as soon as I cue this up, we've got Hilton next. Go for it.
Aloha, and thank you, Beth, for the opportunity to be here. I'm just going to talk for a few minutes. I'm doing a presentation with Dr. Ashton from Hawaii Pacific Health about payer-provider collaboration and what we're doing. So I'm just going to set the stage for a few minutes. And just back up, because I just want to give some context for the relationship we are heading toward, or we have with Hawaii Pacific Health and other payers. But when I think about healthcare, and we've been hearing about that a lot today, we don't really have a healthcare system in the United States. We actually have a sick care system. And the reality is we've overwhelmingly focused resources on hospitals and operating rooms and technology and equipment, and we're great at providing world-class care once people get sick, okay? And the health insurance industry, which I'm now a part of, has paid for people. We pay for people once they get sick, but typically and historically, we've not paid for things that stop them from getting sick in the first place. And so the healthcare industry has incented volume through fee-for-service payments. That's what we've done, and what we've got is hospitals and doctors that just, that work on volume. So what we've created is a system, and you've seen these numbers today, that consumes almost 18% of gross domestic product nationally, that has material unwanted variation, and in which the typical consumer is not engaged. And you heard some of that about the engagement of the consumers at our lunch speaker today. So where are we going, and what are we at HMSA doing to do that? We're now partnering with physicians, physician organizations, hospitals, and other healthcare providers. And some of the goals we have is to improve the incidence of evidence-based care. Now, there's not evidence for everything that's done in terms of healthcare, and we all know that. But where there is evidence, we want to follow that and we want to incent that. There's a lot of variation in care. We have a lot of great doctors, a lot of great hospitals in Hawaii, but there's huge amounts of variation. No matter which metric you look at, there is a lot of variation, and one of our goals is to reduce that variation. We want to improve patient satisfaction and engagement. The average consumer is not engaged with their physician or their care team. We want to reduce the rate of healthcare increase, and we want to improve the overall health and well-being of the people of Hawaii. So in terms of working with Hawaii Pacific Health, in terms of that context, there were some joint principles that we developed. We wanted a long-term, mutually beneficial, transformative model. Now, historically, for those of you've been involved in negotiations, a lot of negotiation, a lot of contracts have been 1-year or 2-year contracts, and it takes it takes time to affect change, to move from where we've been to where we need to be. So we mutually decided that we needed a long-term commitment on both sides. And there needed to be full transparency in terms of the economics of the deals. Historically, there hasn't been a lot of information sharing between payers and providers. It's been very much closed systems on both sides. We wanted a system that was payer and provider neutral. What that means is that we could enter into this similar type of arrangement that we're entering into with Hawaii Pacific Health with other providers, and they in turn could take that same principles and work with other payers. And we decided that we were both going to invest in tools and systems. And this is what we wanted to do, was to bend that cost care trend. I don't know exactly what % of gross domestic product we spend in Hawaii. I've heard some numbers. Nationally, we spend about 18%. The evidence says we probably spend somewhat less than that. I don't know exactly what that number is. But regardless of what that number is, what we're most concerned about is a year-over-year increase in the healthcare trend, and that's something that we want to bring down. We've talked about quality of care. We talked about transparency and data and outcomes and costs. And when we talk about transparency, we're not talking about publishing our rates with Hawaii Pacific Health. That's not what we're talking about. What we're talking about is transparency in terms of outcomes, in terms of quality metrics. We're not, we're doing transparency right now within hospitals, within physician groups. We're not doing it, out there to the general public just yet, but that's something that we want to get toward. It was interesting, that point that was made earlier today about costs and transparency, where one of the speakers made the comment that, if you put like in Massachusetts, when they put the numbers out there and people look at high cost and low cost doctors and hospitals, and there is that assumption that a lot of us have that, okay, well, I want to go to the consumer says, I want to go to the highest priced doc or the highest priced hospital because they're probably better, right? And then the doctors that aren't earning as much, or the hospitals are not getting as much from the payers, say, look, well, why aren't I want to get higher costs. So transparency, it has both pluses and minuses. We talked about trust and collaboration, and that's something that we're doing now. Many of you have probably worked with HMSA over the years. There hasn't been as much trust or collaboration as there could have been. we're doing things very, very differently now. We're collaborating with hospitals, with doctors, with hospices, with primary care organizations, where there's a huge amount of partnership that's going on. And we also have a shared responsibility for the healthcare cost trends. You know, it's when you think about a hospital, they've got a huge infrastructure, and they've got all these resources, they've got operating rooms, they've got buildings. The question is, how do we get through this transition from a fee-for-service volume-based model to a population-based model, and how do we talk about a soft landing, how do we work with the hospitals to get through that? And that's a challenge. So I'm going to turn it over to Dr. Ashton now, but we are very, very pleased to be working with Hawaii Pacific Health on this model. It wasn't easy. David Okabe, who's in the audience, was sitting on the opposite side of the table with us for quite a few months, actually. We got to know each other very, very well, apart from the fact he used to be my boss, but, you know. But it was a long journey, it was a tough journey, but we're in a place now that we believe we can provide a much, much better collaborative model of care to our members and set an example for how we want to work with other hospital systems in Hawaii. So thank you.
Okay, so thank you very much, Hilton. And now we'll hear the following points from Dr. Ashton.
Thanks very much, and good afternoon. I'm going to try to give you the Hawaii Pacific Health perspective on this, this shared vision that we have with HMSA. And I wanted to start, I'm not going to do a lot of nuts and bolts and how we structure things and what our legal formation is and all the rest of that. I don't think that you necessarily need that, but I wanted to give you a sense of what our motivation is. So let me start here. So I can tell if we're going to have a good financial month for the system, for hospitals, by how many really sick babies we have in our NICU. There's something morally wrong in hoping for sick babies. So this was our president and CEO, Ray Vera, who said, we need to switch our payment systems so we're rewarded for the quality of care we provide, not the number of sick babies in our hospital. And so that's really, I think in a nutshell, our motivation. We do quite well under the fee-for-service system, but we don't believe it's the right system to continue to function in. So let me show you a little bit about how we do in our newborn ICU care, because we have a lot of really sick babies in our NICU, but we take very good care of them. So what I'm showing you here, the Vermont-Oxford network is a network of neonatal ICUs across the country. About 55,000 babies under 1,500 grams or less than 3.5 pounds are depicted here. And it's our performance compared to the Vermont-Oxford performance. The red lines that you see above the bars, that's the average for the same type of NICU that we have at Kapiolani. The dark blue line is the top quartile. What you can see there is that in the first two sets of bars, those are conditions of small babies. So those babies under 3.5 pounds, less than 29 weeks. And the first one is necrotizing enterocolitis. That's a condition where the blood flow to the intestine is interrupted and the intestine dies. Those babies are incredibly sick. Many of them die. If they survive, they often have ongoing healthcare costs that keep them in the hospital for months or years, and they need ongoing care for their lifetime. That's a very expensive kind of care. The next set is nosocomial infection, infections that are acquired as a result of the health care that those babies receive while they're with us. And you can see in both of those sets of data that Kapiolani has done exceptionally well compared to the network, and we've improved year over year in all of those. The last two sets of bars are all babies. We take care of about 900 babies a year in our NICU, so that's looking at the care that we provide to all babies in two areas, the nosocomial infection rate and whether they need oxygen when they go home from the hospital, both measures of good care in an NICU. So the point here is we take very good care of those babies that bring in a lot of dollars to us. The better care we provide to them, the fewer dollars we receive. That's pretty perverse and not what we really are about. this is what we're about. The upper picture on the left side is a picture of a baby called Leila, who was born at 24 weeks. 14 weeks later, as she was getting ready to go home with her very happy parents, the whole point being, this is the kind of outcome that we want. This baby went home without any of those consequences of being born extremely premature. But the payment system doesn't support doing this. And so we're motivated to change our payment system so that we can do more of this kind of care. And there are examples of all kinds of care. It's not just in the NICU, it's throughout our entire health system. We need to get the payment system to fit the kind of care that we want to provide. So here's our sustainable healthcare goal, and it's a whole lot of words on a slide. So let me make it a little easier to point out what we really care about. We want to create a value-driven healthcare delivery system with clinical integration, has already been described several times today. We want to do population management with a network of employed and independent physicians, so expanding beyond our employed physicians, and by establishing partnerships with payers, with HMSA being the example that we're talking about today. And oh, by the way, without going broke, right? Critically important that we maintain our ability to provide the care to the patients that we see. So without going broke is kind of important. So we have some fundamental beliefs. We actually do not believe that there will be regular increases in fee-for-service payments going forward. We don't think there's more money to put into healthcare. We do think that hospitals and physicians need to partner to provide the highest value care for patients. Neither hospitals nor physicians can do it alone, and if we're going to be providing population health, we have to provide healthcare outside of the hospital walls. And to do that, we need a health plan partner who shares our vision of sustainability. At Hawaii Pacific Health, we've actually demonstrated our ability to measure our performance. We've had a number of opportunities to do that, and we do quite well. We've also demonstrated our ability to improve clinical outcomes in a number of areas. So here's some examples for ambulatory care. This is in the population that we measure, that we share with HMSA. So in the diabetes measures, this represents just under 4,500 patients with diabetes. And we're in the top 10% in the country as measured by HEDIS at the end of 2012, audited data for LDL control, not just whether we measured it, but whether we actually had patients with cholesterol under control, whether the blood pressure was under control, whether we screened accurately for kidney disease. The blood pressure control is about 8,000, actually almost 9,000 patients with hypertension, not diabetic, and whether their blood pressure was controlled. So pretty good results that we've been able to achieve as a result of focused work on improving care. So we've worked together with HMSA now for a number of years. This new role that we've got starting in January is just an extension of things that we've already been able to demonstrate. We've spent a lot of time getting to know each other, and we've actually learned to discuss what matters to clinicians in terms of metrics that matter. And we've had some kind of ornery conversations, I must say, probably more ornery on my part than theirs, and talking about things of, keep out of our business. We provide the health care. Don't tell us how to do it. We'll figure out how to do it. Just tell us what you want. And I think that's worked quite well. And we are learning more and more to share data. One of my favorite quotes is that every system is perfectly designed to achieve the results it gets. The fee-for-service system is perfectly designed to achieve the results we've had. We have plenty of systems to change as we move into a different payment system. We have to change the way physicians interact with team members. We've heard a lot about that today. We have to change the way physicians think about their panel of patients, not just the patient in front of them, but the patients that are not coming in to see them. There are a whole number of things that we have to work on. But we're chipping away. And we were asked to talk about our expected outcomes. I think these are the particular things that we're very interested in achieving. We do want to see a reduced rate of rise in the medical cost trend while delivering on measured improved quality. We are going to be and are already working on integrated care for a larger population of patients. And the reason I added in there anticipated change over time is that we know that although we've got a contract now that will last for 5 years, it's quite likely that what it looks like in 5 years and what it looks like today are going to be quite different. So we expect that this will change over time. So thank you.
Thank you very much. Sorry about that.
For those of you who don't know me, I'm Dr. Palafox. So our path to accountable care is also in partnership with HMSA. But as you'll see, we're at a very early part of this journey. Let's see. Oops. It's always, if we're going to look ahead, it's always a good idea to look back and to learn from history. Much of what we're talking about today is to contain the cost of healthcare. And if you look at the cost curve, you'll see that in the 90s, cost was contained. And that was during the managed care era. But it failed. After the 90s, the cost started rising again. Why did it fail? And I found an interesting example. If you look at treatment for metastatic breast cancer. So in the 1960s, an oncologist by the name of E. Donnell Thomas up at University of Washington sort of discovered a cure for leukemia, for certain types of leukemia. He did a bone marrow transplants for these patients, and then interest followed for solid tumors, and eventually people say, well, maybe we ought to do this for breast cancer, for metastatic breast cancer. And in fact, this gentleman from South Africa published an early trial, and he showed some success with using bone marrow transplant for metastatic breast cancer. Early result. And appropriately, the insurance companies considered that the treatment experimental. But there was so much suspicion and distrust, people started suing the insurance companies, and in fact, some states mandated coverage for coverage for bone marrow transplant in the setting of metastatic breast cancer. And then more data came in, and in fact, what they found was that there's no benefit to using a bone marrow transplant, and in fact, there's some harm. The only study that showed some benefit came from the South African group. And so they went to South Africa, they looked at his data, and they found that he had fudged the data. And what happened was he was dismissed by the university. So, and in the end, the insurance companies won the battle, but they lost the war. And the reasons are there was this perception that they were putting profit over quality, and that there was lack of payer-provider alignment. Now, in 2013, we're asked to increase costs, decrease quality, and increase quality and decrease cost. And much of what we are seeing today is collaboration between the payers and the providers on the mainland, and certainly here in Hawaii. Melinda and Hilton just gave you an example of that. And we're working with HMSA on a collaborative model that I'll share with you in a few slides. But I want to show you this slide because it gives you an idea of the challenge that we face at Queens. So in 1917, the American College of Surgeons formed this committee that eventually became the Joint Commission. And early on, they decreed this church and state-like separation. So what they said was, hospital management, you take care of the facility, you hire the staff, and you handle the finances. And you doctors establish the standard of care, credential yourselves, and oversee the peer review process. And the payers, for the most part, maintain separate revenue streams. And at Queens, we have 1,200 physicians on the medical staff. And up till 5-6 years ago, those physicians were pretty much in groups that contracted with Queens or they were in private practice. And now we have employed physicians, but they comprise approximately just 10% of the medical staff. So most of the physicians are independent, fairly confident, completely happy doing what they're doing. And that's the challenge that we face at Queens. All right? So our strategic imperatives includes formation of a clinically integrated network. And this network incorporates three major groups: the community physicians, the physicians who contract with us, ER physicians, radiologists, pathologists, and then our employed physicians. And there's about 130 physicians who are employed at Queens. In 2012, when I took my position, we convened a group of medical staff leaders, and we asked them, how should we proceed? How do we travel down this path to accountable care? And there was agreement that we shouldn't employ everybody. And there was also agreement that we shouldn't maintain this loosey-goosey relationship. We need to have something tighter. We need to form a clinically integrated network. And so the decision was made to form a QCIPM comprised of three groups: the employed physicians. Let's see, there's no arrow here, huh? Oh, here we go. The independent community physicians. And then the third group is comprised of IPAs, or physician organizations. And we identified 4 physician organizations to work with: PMAG, Hawai'i IPA, HQPO, and Oahu Physician Group. And these are the groups who represent the primary care physicians in the community. Many of these primary care physicians don't even have privileges at Queens. And so this is our way of trying to reach out to them. And our goal is to work with HMSA and have pay-for-performance contracts and bundle payment contracts. What we're doing is to try to extend the PCMH care model to form a patient-centered medical home neighborhood. And this neighborhood will have private practicing physicians, specialists, and hospital-based physicians. And our initial goals are to target transition of care and to develop protocols that address the triple aim, and hopefully we can have payment models aligned to them. So how is the CIPN, how is this network different from managed care? Well, there's more knowledge about healthcare cost. We know that a small percentage of the population is responsible for 2/3 of the healthcare expenses. There's improved IT technology. There's more data, more guidelines and quality metrics to track. There's greater collaboration between the payers and the providers, and the physicians are given more control. This actually concludes my slide. Okay. So I think this is the time for questions, right? Yes. Perfect.
Thank you very much, Dr. Limm. So I think that is the perfect slide to leave up there for the question slide. And as you are formulating your questions, and we do have a mic here, and I invite you to come forward and do that, but I'm going to give these guys a warm-up question. And the question is, over the past 3 years, what have been the greatest challenges? And looking forward over the next 3 years, what do you anticipate will be the greatest challenges for integrating healthcare? And Joan, is it fair to go ahead and ask you that? Because healthcare is certainly changing all around us. So even though you've already been integrated, how are the changes in the healthcare system affecting you?
You know, we've had an integrated model at Kaiser for 50 years, but it's that relentless pursuit of innovation that means you're always changing and always moving forward. Layered on top of that are changes to metrics that we all use in our community. We've seen HEDIS metrics and NCQA, all the different metrics, HCAPS and CAPS. And when you're working in a system that already exists and then you're layering on all of the metrics, it's a piece of it that you have to keep working with to make sure that we're all working with the correct metrics, and that we also follow any unintended consequences of metrics and make sure that we don't allow those to slip into our systems. So I think those are some of the important things, that you have to have the metrics, but you also have to constantly be looking at the metrics that you use and make sure that they are driving the correct results that we want, and that we are developing the system that does get the results that we want. And as we look forward to the next 3 years, I think that it's going to be staying ahead of the curve and innovating in the world of healthcare reform, which is really what so much of what today has been about, as we as a nation transform our healthcare system, not just here in Hawaii, but how we in Hawaii will actually be the leaders in that.
Thank you, Joan. Hilton, same question for you.
So one of the biggest challenges that we have faced as a payer, because we are a payer, is trust with providers. I alluded to this issue in my short presentation a little while ago. Historically, and I've been on both sides of the table, or both sides of the fence, or whatever it is we sit on either sides of, but the relationship between payers and providers historically, Kaiser was obviously different, being an integrated system, but for the rest of us, it has not been easy. And to overcome those issues of trust, it's taken a lot of work and it takes time. I talked about data sharing, I talked about partnership, I talked about commitment to a course of action, so that we're not, every year we don't change the rules or change the direction we're going. So trust historically, and overcoming trust, and we're very, very fortunate in Hawaii that we have a smaller number of players to deal with, but that has been a challenge for us. In terms of going forward, we reached a tipping point a few years ago in terms of this whole issue of costs and the percent of the GDP that it was consuming. People have talked about healthcare for a long time, but it hasn't really been at the forefront of a lot of different. It hasn't been at the top of a lot of different lists, but now it's at the top of a lot of lists, both for employers, for members, for hospitals, for state and federal government. So we did reach that tipping point, and the question is, okay, so where do we go nationally? We've got the Affordable Care Act, and who knows what's going to happen next week with the Affordable Care Act, but hopefully it will settle down soon, so we can all figure out what it is, both the providers and consumers, where we're going. I was on the mainland last week, and it was just really interesting listening to different people and from different parts of the country. People understand generally that we've got to change as a community. The Affordable Care Act certainly has a lot of noble aspirations. It has a lot of good components to it, but it doesn't in itself address a lot of the issues that we are talking about. So the question is, how do we collectively deal with that? And there's a lot of people doing a lot of different things, but is there one course that people are gravitating toward? Absolutely not. So trying to figure out, where we're going to be 5 years from now. We know we need to move away from fee-for-service. We need to move toward value. Need to get members engaged. But exactly what the models are going to be, we're still figuring a lot of that out.
I think a challenge has been living in two worlds, living in the pay for volume and pay for value world. With the primary care physicians, they are being paid for seeing patients and also for the quality of the work that they're doing. That's not necessarily the case with the specialists. Most of the specialists are still in the volume-driven mode, and I think I think what we're trying to do is get their attention by sharing quality data with them, and that's important. But I think at some point there needs to be some financial incentives or disincentives behind that.
Thanks. think in terms of changes over the last 3 years, the big changes that we've been dealing with have been the transition to much more of our success being tied to quality metrics, and getting those quality metrics well designed, getting them accepted, and then spread throughout the organization so people really know what it is we're trying to achieve. I'm concerned that over the next 3 years, one of the things that's going to be very challenging is going to be bringing physicians along, particularly independent PCPs, along to the place where we all want to get eventually of really having, highly functioning patient-centered medical homes. I think at the moment, a lot of primary care physicians in Hawaii are really feeling the burden. And I go to many meetings, and I keep hearing more and more about what a PCP is going to do next. And I think we're in for a rocky road for a little bit.
Thank you. And now I'd like to turn to the audience. Would you please identify yourself and then ask your question?
John Hauk, I'm a primary care physician. Is it working?
Yes.
My question is for Hilton and Melinda, and maybe you just answered it as I'm standing here, but I got the impression that you sat and talked for a long time, and at the end of it, you maybe sang Kumbaya, but I'm not sure about the specifics of the 5-year contract that you did. You gave us a very high-level presentation today, and I'm not even sure if you can share this with us, but can you be a little bit more specific in terms of what's in that 5-year contract and exactly how you moved away from fee-for-service to a more collaborative arrangement?
Well, there's a couple of people in the audience who know much, much more about the contract than I do, but I'll give it a shot, Dr. Hauk. It's certainly a significant portion of the revenue for the next 5 years with Hawaii Pacific Health from HMSA will be tied to quality than what it is right now. So there are a number of metrics in that. There is a hospital quality program focused on things about readmission, patient harm, surgical complications, end-of-life care, things like that. And there are material incentives on the primary care side around patient-centered medical home, evidence-based care about things like diabetes, hypertension, asthma, HEDIS metrics, things like that. But one of the more noticeable differences in the contract is it's about it's the health of a population, but it's also the cost of taking care of a population. And so there are mutual incentives in our contract with Hawaii Pacific Health to accept joint responsibility for the total spend for that population. And so we're monitoring that, and the reimbursement, some of the reimbursement in the contract is directly tied to that rate of spend compared to what's happening in the state. So accepting Hawaii is a relatively risk-adverse population. You go look at a lot of other parts of the country, and a lot of other groups and hospitals accept much more risk. Hawaii typically is risk-adverse. So this is a step toward moving, and we're the insurance company. We do not expect hospitals and physicians to take on global risk for patients. That's our job, is to aggregate that risk. But should there be some accountability? Absolutely, we believe there should be some accountability and shared accountability. So that's, hopefully, Dr. Hauk, that answers the question.
And just one comment: we don't have any incentive for that reduced medical cost trend in terms of shared savings until we hit the quality targets that were set for the hospital quality side. So we have a strong incentive to deliver on the quality so that we can then share in the savings.
Is that it?
Yes, please.
Okay. Hi, I'm Richard Leaching from Hilo. And I'd like to commend HMSA for working with the East Hawaii IPA on the creation of a community-based integrated system in ACO. We've been working on an information platform with outcomes, and doing this in a rural, non-staff model community system has been really difficult, but it's been worthwhile.
Thank you very much.
Hi, I'm Dr. Pang. I'm the health officer for Maui County. I appreciate you watching the metrics change. I appreciate you trying to share the costs, the savings of averted costs. But let me just bring up one more point here. The game is changing very quickly, sometimes faster than your metrics can detect it. And I'm talking about obesity and the way we live. I'm talking about elderly trying to die at home. I'm talking about behavioral health and substance abuse. And sometimes your metrics in your four walls aren't good enough to look at what the community can contribute. And I'm asking you to come a little bit farther outside, and if we can show the bang for the buck in community-based programs, to please support those. And I'm setting it up for the next question here.
Thank you.
Thank you, Dr. Pei. Leila Parlin with the Hilo Pa Family to Family Health Information Center. I appreciate the tremendous amount of work that you've all done in no time. You know, in the course of the time that you've put together the organizations, they've happened overnight. And kind of fast forwarding it, my question would be, you know, where do you see the community in this medical neighborhood? Where do you see the community? Because you cannot do it without the community. And second part to that, where is your consumer representation within the organizations to kind of be that sounding board and provide the voice?
Thank you. Who wants to take that? Who'd like to start?
Well, if I actually, both of those comments there, you know, we've been working with Hawaii Pacific Health for, the new contract starts January 1 of 2014. It runs for 5 years. We started, actually 2 years ago. We started in December about 2 years ago. So it took us 18 months to negotiate the contract, and since that time, the market continues to evolve, and we've continued to evolve. So the contract that we're about to embark on actually is, in some ways, it's a little bit already outdated, even though we haven't even started yet. And one of the ways it's outdated is that we are moving, it sounds like iPhones, doesn't it, and iPads, you know, buy the latest one and walk out the store. And anyway, one of the ways it's outdated is that we at HMSA are now focusing on exactly what you're talking about, which is the population, the health and well-being of the population, and moving way beyond the walls of the hospitals. You know, as I talked about earlier in my presentation, you know, we have a sick care system. We've focused historically on taking care of people, but it's very, very reactive model. You wait till they get sick, and then we've got great docs, great equipment, great technology, great scans, everything else. What we want to do now, and what we're looking for as we're looking toward the future, is how do we, you know, move upstream? How do we get out there in the community? How do we stop people from getting sick in the first place? How do we engage the community? How do we work on preventative care and send preventative care? And do it in a, so that's where we're going right now. So, you know, we're not gonna tear up the contract with Hawaii Pacific Health just yet. But you know, we need to at least get it started. But you know, that's where we're going. So,
and I would suggest that we don't need to tear up the contract just yet, because part of the incentive, you know, the medical cost trend, shared savings part of the contract. The only way we'll get there is to go to population health, community partners. So it's absolutely the right incentive for us to do the next set of things that have to be done. But we have to start where we start.
I would agree. I mean, this is a journey. It's an evolution, and you can't. You know, we have to get the hospitals and the docs and the community to come along with us. And so it'd be great if everything could change overnight, but it's not going to change overnight. So thank you, Dr. Ashton.
Joan or Whitney, comments?
I guess there's a question about consumer involvement. I guess we have a community representative in our quality and safety committee. We found someone who's constructively disgruntled. And you know, we're opening up west, and we are going out into the community, trying to identify the needs that they have as we prepare for the opening.
And I will just add, sort of layering on top of obesity and many of the things that are in our communities, engaging the patients and having them involved. But you know, it's really hard to crack the nut on obesity and some of the other chronic conditions that we have in our communities. But you can use electronic medical records, which are now becoming more and more common across the state, to really help with many chronic conditions, such as making sure that patients with asthma are properly taking their meds and that they're getting their prescriptions filled and that they're getting the follow-up. And you can use electronic medical records to prevent fractures by identifying patients and making sure they're getting the proper interventions to keep from having bone fractures. So there's a lot that we can do, but we have to have our community engaged and have them participating within their own health care.
Thank you. Last question.
I'm Martin Johnson, clinical psychologist. Could each of the panelists talk about a little bit how you see behavioral health and the role of behavioral health in integrative care going forward? Wide open.
Great question. Joan, why don't you start and we'll go down the row.
Okay. You know, behavioral health is something that has received a lot of focus over the last, I guess, decade or 15 years or so, and continues to receive focus. And within the integrated model, you really have to have a lot of focus on behavioral health and similar issues, because they're part and parcel to so many of the other population health issues that we work with in our communities today. And I think that more and more we're finding that focusing on behavioral health actually can improve outcomes as a whole. So it must be part of the integrated system, and within our integrated system at Kaiser, that certainly is part of the whole in the services that we provide, part of the continuum of care and part of the coordination of care. So I think it's very important that it actually be fully integrated into the continuum of patient care from end to end.
In general, we as a community and as a nation have not dealt as well as we could have with behavioral health issues. So that's just like we're shifting focus. We at HMSA have shifted focus onto primary care and invested a lot in primary care. Behavioral health is one of the areas that we're spending more time looking at and reaching out to people in the communities and say, how do we better take care of our members with behavioral health concerns or issues? How do we improve overall health and well-being? So it's something that's been very underserved and definitely needs more attention, and it's getting attention from us, and I know the state and other players, providers out there in the community as well.
Karen Schultz, our VP of Psychiatry, is sitting there, and I can give you her cell phone number. I think Queens has been a strong supporter of behavioral health. We do have the inpatient and the outpatient psychiatric units, and we will continue to provide that service.
So I think on the other end of the spectrum from the inpatient psychiatric unit is that much of behavioral health is actually managed by primary care physicians. One more thing on the list for a PCP, and we know it's not done well. And so we know that at least in our system, that is a weakness. It's something that we have to work on. There are lots of good models across the country as to how to help primary care physicians do a better job, and then to integrate with the behavioral health specialists as well. So it's something that we've recognized as a weakness and something we're working on.
Thank you very much. And I also appreciate that question, because as we were working with all of our committees in our health planning process, we heard over and over again, every single committee, about the crisis in behavioral health. And so we are fully aware that we have problems with access, problems with definition, problems with providers. We have just got to all work collectively on improving our behavioral health system in very many different ways. So I think that that is a very fitting way to end this particular session. And we now have about 15-minute break, coffee break in the vestibule. Please do visit the exhibitors if you haven't already done so. Drop off your card, because I know now that you've heard Dr. Verghese, you will want his book. Thank you.
Very good job.
And that little flub
I thought you got the other great presentation. That's why I said well done, and when the crowd laughed.